This session will delve into critical and current topics in obstetric anesthesia.
We'll be covering applications of ultrasound in obstetrics, latest developments in oxytocics during LSES, and how to manage obstetric emergencies with a calm head and sharp skills.
To chair this session, now we invite Dr. Akhil Rao, Professor, Srinivas Medical College, Dr. Murli Krishna V, K. Segde Medical Academy, Dr. Govind Rao Hagargon, freelancer anesthesiologist, Sindhanur.
We now hand over the proceedings to the chairpersons.
Our first speaker for this session is Dr. Vinay Marula Siddhappa, Professor in the Department of Anesthesiology at Mangaluru Medical College and Research Institute. We welcome you, sir, to speak on POCUS in obstetrics, ultrasound or crystal ball.
Good morning, everybody. So today I'll be talking about POCUS in obstetrics, ultrasound or crystal ball. So first of all, what is POCUS? See, POCUS stands for point of care ultrasound. That means we take the ultrasound to where the patient is. That's the bedside of the patient, whether the patient is in the OT, ICU or ward, and do the ultrasound for diagnostic or therapeutic interventions. Now over the past few years, POCUS in obstetrics has established itself so much, it is now recognized as a distinct entity and a separate terminology has been coined called OPOCUS. OPOCUS means obstetric POCUS, which has become an absolutely essential tool with the obstetric anesthetist. The advantages of OPOCUS is it's non-invasive and it is not harmful. It doesn't emit any harmful radiations unlike your chest X-ray or the CT scan, so it's being widely used. Now, what are the applications of OPOCUS? See, OPOCUS can be seen as this big umbrella under which there are several applications such as airway evaluation, guidance of central neuraxial blocks, lung assessment, cardiac assessment, performing nerve blocks, vascular access, evaluation of obstetric emergencies, monitoring ICP, DVT, and even using the gastric ultrasound. So from head to toe, you have several applications like optic ultrasound, airway, lung ultrasound, gastric ultrasound, cardiac and vascular access. So airway assessment, I think Dr. Anil has already dealt in detail. I will only tell the portion which is relevant to obstetrics. See, in obstetrics, the anatomical changes such as and physiological changes such as airway edema, breast engorgement is going to complicate the airway management. Airway is difficult in obstetrics. So here, obstetric POCUS helps us in several ways. First is to evaluate and predict difficult airways. Second, most importantly, to recognize the cricothyroid membrane. So when is this important? In a CICO situation. Cannot intubate, cannot oxygenate scenario. It is very important to quickly identify cricothyroid membrane, which is seen as a transverse hyperechoic structure between the cricoid and the thyroid cartilage. You can also do the longitudinal method where you can see the cricoid and the thyroid and the cricothyroid membrane in between. Of course, the tracheal cartilages is seen as this classical string of beads sign in the longitudinal plane and in the transverse plane as an inverted U-shaped structure. Now, ultrasound in recent years has been used to identify the position of the endotracheal tube in the trachea. This is especially useful in situations where EtCO2 is not helpful, like say a patient with cardiac arrest or a patient with severe bronchospasm. You cannot pick up the EtCO2. You can use quickly the ultrasound to locate the endotracheal tube where it produces a characteristic bullet sign. What is this bullet sign? You get a large posterior mucosal interface beneath the endotracheal tube, whereas if the tube is in the esophagus, you get the classical double lumen sign or the double barrel sign. Moving on to neuraxial techniques. So we all know that central neuraxial techniques like spinal and epidural are absolutely important, fundamental for obstetrics, especially for labor analgesia and for spinal and epidural for cesarean sections. The problem with these traditional landmark techniques is these blind techniques rely on appreciation of these landmarks, which may be difficult, especially because of the edema, the anatomical and physiological changes. So we use the ultrasound to guide the central neuraxial blocks, which is what the NICE guidelines even recommend. So this is a particular view we are going to use for ultrasound guided spinal or epidural called as the TI view. TI means transverse interlaminar or transverse interspinous view, where you place the probe in the transverse plane, just tilt it slightly so that the beam passes between the spines and you get this classical bat wing sign. That is the classical appearance you get, wherein you can make out the intrathecal space. See, this is the intrathecal space seen as a hypoechoic shadow between the anterior complex and the posterior complex. So this is clearly seen in this thing. This is the intrathecal space. For epidural, it is located between the dura mater and the ligamentum flavum. This is the epidural space. Now, once you locate the spinal or the epidural space with the ultrasound, you can do two important markings on the skin. One is the midpoint of the probe's long edge, which gives you the neuraxial midline. The other is the interspinous line. The point where these two lines meet, that is the point where you have to insert your spinal or epidural needle. The rest of the technique is like your conventional landmark. That is, you have to go by feel, the ligamentum flavum and loss of resistance. This is your ultrasound guided spinal or epidural. Now moving on to gastric ultrasound. Now gastric ultrasound in pregnancy helps us to predict those women who are at a high risk for aspiration. Thereby you can take the appropriate precautions. Now in gastric ultrasound, we are mainly looking at the antrum of the stomach, which is located between the liver and the pancreas. You can measure the cross-sectional area of the antrum, and from that you can calculate the volume of gastric contents using this formula. You can also identify what type of gastric content, whether it is a solid, liquid or the gas. And only thing is, in pregnancy, we should not use the supine position, especially in the third trimester, because it can cause the supine hypotension. So you can go for a right lateral position and locate the antrum between the liver and the pancreas. So these are three important gastric ultrasound which I have displayed. The first one is that of an empty stomach, where you can see the antrum is completely collapsed. You can see the antral lumen, it is collapsed. This is the stomach of a patient who is empty and therefore low risk for aspiration. Whereas this one is a patient who has taken solids, where you get a classical distension of the antrum and the frosted glass appearance. See, that is the frosted glass appearance because of the mix of air and particulate matter. And the third one is the ultrasound in a patient who has taken liquids, where you get a classical starry night appearance. You can make out the stars, kind of stars in the background of the night. That is because of the air bubbles in the background of the liquid. That is the patient who has taken liquids. Now you can actually grade the patient depending on the ultrasound. Grade 0 is antrum is empty in both supine and right lateral, low risk for aspiration. Whereas grade 1 is antrum is empty in the supine. You put them in the right lateral, you can pick up the liquid, but the volume is less than 100 ml. Again, this is the low risk for aspiration. Grade 2 is you can see the fluid both in the supine and right lateral. Most importantly, volume is more than 100 ml. That is a patient who has at high risk for aspiration. Moving on to lung ultrasound. Now, lung ultrasound specifically in obstetrics is very important. If you do a lung ultrasound in a patient with severe preeclampsia or HELP syndrome, you can pick up pulmonary edema long before even the clinical signs and symptoms such as desaturation and Krebs and all those things have appeared. Long before that, you can pick up how? By looking at the classical B pattern. So you get vertical hyperechoic lines. You can make out here, these vertical hyperechoic lines are the B lines, that is the B pattern, which is seen in pulmonary edema, whereas in the ultrasound of a normal patient, you get horizontal hyperechoic lines called as the A lines or the A pattern. I'm sure you're all familiar with the pleural line and the lung sliding underneath it. Now, these are the lung ultrasound in specific situations. See, lung ultrasound can pick up the pneumothorax, wherein you do the scan in the anterior plane, change it over to M mode, you get the classical barcode sign, means you get series of parallel lines which looks like a barcode. That is a barcode sign in pneumothorax, whereas in a normal lung, you have parallel lines at the top, sandy granules at the bottom, that is the seashore sign. Similarly, lung ultrasound, you can pick up these shred sign or hyperechoic patches in a pneumonic consolidation, and at the bottom you have the lung ultrasound classically in a patient with pleural effusion, wherein you can make out the transverse process of the thoracic spine. So you can see that here. So this is a spine sign positive, which is seen in pleural effusion, whereas in a normal lung, you cannot make out the thoracic spine. Now moving on to the heart. Now what is the difference between cardiac focus and TTE? See, cardiac focus is focus. Focus stands for focused cardiac ultrasound, which is a very simple superficial ultrasound of the heart, which most of us can perform with a little bit of training, of course. And you can pick up gross abnormalities, like any gross biventricular dysfunction, gross valvular abnormalities, large amounts of pericardial effusion or severe hypovolemia. These are the things which you pick up by a simple cardiac focus. Whereas TTE, transthoracic echocardiography, is the full-blown, the comprehensive study which is done by the trained people, that is the cardiac anesthetists or the cardiologists. Now, what about obstetrics? See, in obstetrics, we have something called ROSE scan. ROSE scan stands for Rapid Obstetric Screening Echocardiography, which, as the name itself suggests, is a screening procedure to pick up, specifically taking into account the anatomical and physiological changes that have already happened in pregnancy. We all know that the pregnancy, the CVS, is sort of a hyperdynamic circulation. So taking into account, you already have the ROSE scan. So what do we do in the ROSE scan? We look at 5 important views: parasternal long axis view, short axis view, apical 4-chamber view, the subcostal view, and we also look at the IVC. Now, each one of these 5 views gives you information about certain conditions, like long axis view for pericardial effusion, short axis for regional wall motion abnormalities. Apical 4-chamber view will tell you a lot of information about the right ventricle. Then IVC, I'm sure you all know, you look at the IVC, especially the IVC collapsibility, to look at the fluid status, the fluid responsiveness of the patient. Now, what is actually recommended is, in obstetrics, it is better to combine both lung ultrasound and TTE, then you get the complete hemodynamic picture of the patient. Because the TTE can tell you things like intravascular volume, fluid responsiveness, and myocardial contractility, whereas lung ultrasound, I told you, can pick up pulmonary edema long before clinical signs. So when you combine both, especially in women with severe preeclampsia, it will give a guidance of exactly how much fluid to give, so that you prevent overloading of the patient, prevent pulmonary edema. Moving on to ocular ultrasound. Now, ocular ultrasound is also becoming very popular nowadays, wherein you place the probe about 3 mm behind the globe. You can see the optic nerve here as a hypoechoic shadow, and around it you get the optic nerve sheath. So you measure the diameter of the optic nerve sheath, what is called as ONSD. Now, if the optic nerve sheath diameter is more than 5.8 mm, it means that the ICP is raised more than 20 millimeters of mercury. This is useful to us in 2 important situations. One is, if the ICP is raised in a patient with severe preeclampsia, we can predict that this patient is progressing on from preeclampsia to eclampsia. Number 2, if we find out that the ICP is raised, obviously it is better to avoid doing the spinal or even attempt the epidural, because sometimes there can be accidental dural tap, and we know that if you give spinal epidural with a raised ICP, it can produce catastrophic complications such as herniation of the brainstem. Vascular access, I'm sure you all use this even in non-obstetric. So obstetric also we use ultrasound for gaining CVP access, peripheral line access, which is actually recommended by the NICE guidelines because it's a lot more safer to do ultrasound than doing it blindly. Moving on to abdominal nerve blocks, ultrasound, I'm sure you all perform these tab blocks on a routine basis, gives excellent post-operative analgesia after cesarean section, wherein we infiltrate the local anesthetic between the internal oblique and the transversus abdominis. So you can see the transversus abdominis being pushed down. So this produces excellent post-op analgesia, which is very useful after cesarean section to ensure good mobility of the patient, thereby preventing complications like DVT. Now, in the ICU, ultrasound is extremely useful, the focus to differentiate between the different types of shock. Many a times we come across these situations where the mother is in shock and we fail to recognize why it is. So whether it is due to severe uncontrolled hemorrhage, whether it is due to sepsis, whether amniotic fluid embolism, pulmonary embolism or MI, that you can differentiate using the obstetric focus. Like for example, if you are suspecting tension pneumothorax, that can be picked up with a lung ultrasound, whereas for cardiac tamponade, hypovolemia, distributive shock and cardiogenic shock, you can use the TTE, and TTE, mind you, can differentiate what is the cause of shock here. For example, for hypovolemia, the VTI, that is the velocity time index is low, and you get the classical kissing heart where the ventricles oppose each other, collapse over each other in severe hypovolemia because there is not much of a blood in the left ventricle. Whereas VTI is actually raised in distributive shock. Distributive shock means anaphylactic shock and those kinds of shock. So to conclude, whether my topic was obstetric focus, whether it is just an ultrasound or a crystal ball, well, if you look, right. So crystal ball, when you look at the Oxford Dictionary, it is this glass device, which I'm sure you've all seen in some of the movies, Harry Potter movies and all that, where the person who can see through this glass device can predict what is the future. Whether obstetric focus is a glass ball, well, although obstetric focus is not exactly a crystal ball to tell you everything about the future, it does help us in predicting the future course of the disease. Like for example, the lung ultrasound I told you can pick up pulmonary edema way before the clinical signs and symptoms. Similarly, the ONST can pick up the raised ICP and can predict whether this patient with preeclampsia is going on to eclampsia. Now, by predicting the future course of the disease, it gives you a window of opportunity where you can intervene at an early stage, prevent the progression of the disease, prevent worsening of the patient's condition. So with its numerous applications, I think obstetric focus has established itself as a very important and a very useful tool with the obstetric anesthetist. So these are my references. Thank you for a very patient hearing. Thank you.
Thank you, sir, for that insightful presentation on the role of point-of-care ultrasound in obstetric anesthesia.